Welcome to This Week in General Medicine. This week, we are focusing on a critical clinical update in outpatient infectious disease management, specifically reviewing the latest evidence-based guidelines for antiviral therapies in adults with mild to moderate COVID-19. We will examine patient selection, drug-drug interactions, and the clinical hierarchy of available therapies. Let's dive in. Managing mild to moderate COVID-19 in the outpatient setting remains a cornerstone of preventing hospitalization and death in high-risk patients, as highlighted in a clinical guideline synopsis. The preferred first-line oral antiviral therapy is nirmatrelvir-ritonavir, which should be initiated within 5 days of symptom onset. This combination therapy works by inhibiting the viral protease enzyme, thereby halting viral replication. Clinical trial data have demonstrated that nirmatrelvir-ritonavir significantly reduces the risk of hospitalization or death in symptomatic, unvaccinated outpatients at high risk of progression. However, prescribing this medication requires meticulous clinical attention. The ritonavir component is a potent cytochrome P453A4 inhibitor, which is necessary to boost nirmatrelvir concentrations to therapeutic levels, but this also leads to significant drug-drug interactions. Clinicians must perform a comprehensive review of the patient's current medications before prescribing. Common medications like certain statins, such as simvastatin and atorvastatin, should be held during treatment and for a few days after completion. Other drugs, such as certain direct oral anticoagulants like rivaroxaban or antiarrhythmics like amiodarone, may pose severe risks, requiring either temporary discontinuation, dose adjustment, or the selection of an alternative antiviral therapy altogether. Renal function is another critical parameter. For patients with mild to moderate renal impairment, defined as an estimated glomerular filtration rate between 30 and 59 milliliters per minute, a dose-reduced packaging of nirmatrelvir-ritonavir must be prescribed. It is not recommended for patients with severe renal impairment, defined as an estimated glomerular filtration rate of less than 30 milliliters per minute. For patients who cannot take nirmatrelvir-ritonavir due to severe, unmanageable drug-drug interactions or advanced renal disease, intravenous remdesivir represents a highly effective alternative first-line option. Remdesivir, a nucleotide prodrug that inhibits viral RNA polymerase, is administered as a 3-day consecutive intravenous infusion and must be initiated within 7 days of symptom onset. In clinical trials, this 3-day regimen demonstrated a substantial relative risk reduction in hospitalization or death among high-risk outpatients. While highly effective, the primary barrier to remdesivir use is logistical, as it requires access to an outpatient infusion center or home infusion services over 3 consecutive days. This can limit its feasibility for many patients, especially those in rural or underserved areas. However, from a clinical standpoint, remdesivir has a favorable profile because it does not carry the same extensive cytochrome P450 drug interaction profile as ritonavir, and recent guideline updates now support its use in patients with severe renal impairment, including those undergoing dialysis, with appropriate clinical monitoring. When both preferred therapies, nirmatrelvir-ritonavir and remdesivir, are not clinically appropriate, available, or feasible, the oral antiviral molnupiravir serves as an alternative second-line option. Molnupiravir is a nucleoside analog that introduces copying errors during viral RNA replication, ultimately leading to viral mutagenesis. It must be initiated within 5 days of symptom onset. While convenient as an oral agent, clinical trials have shown that molnupiravir offers a much lower relative risk reduction for hospitalization and death compared to the first-line therapies. Because of this lower efficacy, it is strictly reserved as a last resort option. Furthermore, molnupiravir has significant safety considerations. It is not recommended for use during pregnancy or lactation due to potential risks of fetal harm. Additionally, male patients of reproductive potential who are sexually active with partners of childbearing potential should use a reliable method of contraception during treatment and for at least 3 months after the final dose. Successful clinical implementation of these antiviral therapies relies heavily on accurate patient risk stratification. The guidelines emphasize that treatment should be directed toward individuals at the highest risk of progressing to severe disease, hospitalization, or death. This high-risk cohort includes adults aged 65 and older, unvaccinated or undervaccinated individuals, and those with significant underlying medical conditions. These conditions include moderate to severe immunocompromising states, active malignancy, chronic kidney disease, chronic obstructive pulmonary disease, diabetes, severe cardiovascular disease, and obesity. Clinicians should recognize that while early clinical trials were conducted primarily in unvaccinated populations, subsequent observational data have shown that vaccinated individuals who possess multiple high-risk comorbidities still derive a meaningful clinical benefit from timely antiviral therapy. Therefore, vaccination status alone should not be used to exclude a symptomatic, high-risk patient from receiving treatment. If you only have time for one paper this week, make it this clinical guidelines synopsis on outpatient antiviral therapies for COVID-19. This concise review provides an invaluable, highly practical framework for navigating the complex drug-drug interactions of nirmatrelvir-ritonavir and outlines clear secondary choices like remdesivir and molnupiravir, helping general medicine physicians make safe, rapid prescribing decisions in daily practice. Here are the key takeaways from this week in general medicine. First, nirmatrelvir-ritonavir is the preferred oral antiviral for outpatient mild to moderate COVID-19 in high-risk adults and must be started within 5 days of symptom onset. Second, always perform a rigorous drug interaction check before prescribing nirmatrelvir-ritonavir, holding or adjusting interacting medications like statins or selecting alternative therapies when interactions are unmanageable. Third, intravenous remdesivir administered over 3 days is a highly effective alternative that is particularly useful when drug-drug interactions or severe renal impairment preclude the use of nirmatrelvir-ritonavir. Fourth, reserve molnupiravir as a last resort oral option due to its lower relative efficacy, and ensure it is avoided in pregnant patients. Finally, prioritize antiviral therapy for patients at the highest risk of progression, particularly those aged 65 and older, or those with moderate to severe immunosuppression, regardless of their prior vaccination history. That's your roundup for this week in general medicine. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. One more note before you go. Only one new paper of note met the bar since the last update. A quieter stretch for new literature. Still worth revisiting from recent updates. Expanding technology-enabled. Nurse-delivered chronic disease care. A pragmatic, randomized effectiveness implementation trial in Annals of Internal Medicine, and towards autonomous medical artificial intelligence agents in Nature. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.